infectious diseases, research, medicine, health. Welcome to Outbreak News Interviews. And now, broadcasting from the Outbreak News Skylar Studios in beautiful West Central Florida, here is your host, microbiologist and editor of OutbreakNewsToday.com, Robert Harriman.
Well, hey everybody, this is Robert, and welcome to Outbreak News Interviews. Now, infectious diseases are caused by pathogenic microorganisms, like bacteria and viruses, parasites or fungi. Now, these diseases can be spread directly or indirectly from one person to another. Zoonotic diseases are infectious diseases of animals that can cause disease when transmitted to humans. Infectious disease medicine requires an extensive understanding of the way in which bacterial and viral, fungal, and parasitic infections occur in humans and how they present clinically, as well as knowledge about antimicrobial agents, antibiotic resistance, vaccines, and other immunobiological agents. Now, my guest today is the author of Gompf's ID Pearls, and she's also an associate professor of infectious disease and international medicine at USF Health, Dr. Sandra Gompf, MD. Dr. Gompf, welcome to the podcast, ma'am.
Thank you so much. It's a pleasure.
Thank you. Well, let's go ahead and start out. What are the Gompf ID Pearls?
Well, the Pearl started quite a long time ago. It started out as a 25-page handout from Dr. John Sinnott, who's then my division director at USF. He's now chair of medicine at USF Rosali College of Medicine. And I had a little spiral notebook where I jotted down interesting or useful pearls since my days as a medical student. Mm-hmm. That's what I do. I'm a hoarder of facts. Once I became an attending, Dr. Sinnott encouraged me to put it all together in a study guide. And, you know, I've used the pearls myself, and I thought others might find it useful. So I did. And the first version I self-published was about 100 pages long, and I just kept adding to it. And once I got to the 4.0 edition and 300 pages, I transitioned entirely to digital because I really don't like killing trees. I've given away the paperbacks for several years before that. Now it's all entirely online. It's been freely downloadable since 2011. I keep other teaching handouts on the side. I keep adding things to it, and I add useful links to other resources I use, and everything is freely accessible. There's no registration or passwords. One of my mottos is that knowledge empowers, and the more you spread it, the better the world is.
Well, there you go. And I did take a look at it, obviously, for this interview, and it's got a lot of very good pearls in it. And let's go ahead and take a look at some of these pearls.
Sure. And
I just arbitrarily picked out ones that caught my eye. Some antibiotics can produce ototoxicity. Dr. Gompf, what is ototoxicity, and what antibiotics can contribute to this serious side effect?
All right. That's an important question. Fortunately, it's extremely rare, but it's something that infectious disease doctors try to keep in mind, along with kidney toxicity. And ototoxicity is just damage to the auditory nerves and the associated structures of hearing. It's very uncommon, but it can cause permanent hearing loss or trouble with balance. And if it's caused by a drug, then the drug should be stopped as soon as possible. In older patients, we worry about and people with kidney problems where they can't eliminate drugs. Usually, this may happen with patients who are on higher doses of these drugs or longer treatments. And some of them we don't really use very often. The three main types are one that we use more often now because of MRSA infections and MRSA infections is vancomycin. Another one is the aminoglycoside group, like gentamicin, and macrolides, like azithromycin.
Now let me go ahead to another antibiotic question. When do you use clindamycin versus metronidazole in covering anaerobic infections?
Yeah, this is a little pearl that I learned early on. Both of those drugs cover anaerobes, or bacteria that can grow without oxygen. But the types of bacteria may be a little bit different, and sometimes medical students can be confused about which drug is best to use. And the easiest way to remember what they cover is by anatomy. So clindamycin covers mostly the gram-positive anaerobes and the few gram-negative ones, mostly the ones above the waist. So you might use clindamycin for infections of the head and neck, maybe, or aspiration pneumonia, or maybe it's often used in dental infections.
Right.
Metronidazole covers more of the gram-negative anaerobes and a few gram-positive anaerobes like Clostridia. And those are mostly found below the waist, so to speak. So infections of the bowel are best treated with metronidazole.
Okay, now some antibiotics are considered bacteriostatic, while others are considered bactericidal. Dr. Gompf, what's the difference, and which antibiotics are considered bacteriostatic?
Well, there's a little bit of debate about whether it makes a real difference, but some antibiotics have their mechanism of action directly killing multiplying bacteria. They're bactericidal. Cidal means kill. And others block metabolic steps that are needed for the bacteria to replicate, like proteins, or for the bacteria to metabolize. And those are bacteriostatic antibiotics. Static means stops. So most of the list of static antibiotics is actually pretty short, which is good. Most antibiotics are going to be bactericidal. The way that I remember which antibiotics are static is a little phrase. One of the first things that we do in sepsis is to restore volume with a liter of stat normal saline. And I remember the first letters of those words. So V in volume is vancomycin, which is bacteriostatic against Enterococcus. And L in liter is linazolid. S is the sulfa drugs in stat. The T in stat is trimethoprim, tetracyclines, and tigecycline. And normal, the NML, and normal is nitrofurantoin. And then the MLS group of antibiotics, clindamycin and macrolides. Everything else is bactericidal. And certainly if any of your listeners have a better way to remember the static antibiotics, I'd be happy to include them in the pearls and give them credit. That's just the way my brain works, and that seems to work for me.
Okay, and as a physician, infectious disease physician, how do you decide on the appropriate use?
Yeah, like I said, it may not make a difference, but I prefer to use bactericidal antibiotics in urgent situations, like a patient has septic shock. That may be more helpful. And on the other hand, and somewhat interestingly, static antibiotics, as I said, they halt the production of proteins. So there are some serious situations where you want to stop toxin production, like in toxic shock syndrome or very severe streptococcus skin infections. So you may add clindamycin to the regimen of those patients. Maybe not alone, but in addition as an adjunct to stop the damage being caused by the toxin.
Okay, let's switch gears to bacterial infections, and we're going to go through some acronyms here. Dr. Gompf, what are the spasic organisms, and why are they significant?
Yes, the spice and spasic mnemonic refers to a group of bacteria that are gram-negative bacilli, usually residents of the gut. And they're a group that may carry inducible beta-lactamase genes. And what that means is that although they may start out as susceptible when you test them in the laboratory, once they're exposed to beta-lactam antibiotics, those resistance genes that are hidden may switch on. And even during treatment, the bacteria may become resistant to the antibiotics you're using. So it's okay to treat milder infections caused by those bacteria with beta-lactams, but maybe use a broader drug like carbapenem for more serious infections. And just it helps to be aware that resistance might become an issue with those bacteria when longer courses of antibiotics are necessary.
Okay, a couple more acronyms, and some listeners out there might be familiar with these. They've been in the news quite a bit in the past year or two. What are CRE and KPC organisms, and what's their significance?
Oh, wow, that's a hot topic.
Yes.
CRE stands for carbapenem-resistant Enterobacteriaceae. And of that family, the Klebsiella and Enterococcus, E. coli, we've got a thunderstorm going on here,
Okay.
are commoner organisms in the carbapenem-resistant Enterobacter group. Other organisms may carry carbapenemases. These the carbapenems are often our last chance or go-to drugs for resistant infection. So when one of these bacteria becomes resistant, we wind up having to use older or more toxic drugs to treat these patients, like colistin. Those drugs can cause kidney toxicity. Mm-hmm. Most people who are affected by these organisms tend to be vulnerable people. They've got weakened immune systems, or they've had multiple medical problems that have required hospital stays and treatment with antibiotics. More generally, resistant organisms tend to be weaker. So healthy people don't typically get sick with them. And you asked about KPC as well.
Yes, ma'am.
KPC refers to Klebsiella pneumoniae carbapenemase, and there's quite a few others that you might hear of in the news. All resistant to, they reflect genes that cause resistance to beta-lactam antibiotics and carbapenem antibiotics.
Okay.
And just to say...
go ahead.
Mm-hmm. No, just one of the things that makes these organisms such a threat is that they're easily spread on mobile genes. Mm-hmm. Those are genes that are not on the main chromosome of the bacteria. They're on a small circular piece of DNA that can replicate on its own, as a matter of fact. They're called plasmids. And so they can be shared very easily with other bacteria, not even within the same group.
Right.
So it's just another way that these resistant organisms can spread.
Okay, let's talk about a vaccine. What is the BCG, and why is it important?
Yeah, BCG is the Bacillus calmette-guerin vaccine, and it's a live vaccine. It's a weakened form of a Mycobacterium bovis, which is the tuberculosis of cattle. And it's very similar to Mycobacterium tuberculosis that affects humans. And because of that, it's effective in preventing serious tuberculous infection in young children. Generally, it's used to prevent meningitis in young children and babies. It's not really very protective for teens and adults, so we really don't use it in that capacity. Where you'll find BCG use is in countries where TB is highly prevalent and more likely to infect babies and kids. So we don't really use it here.
Okay. What is the difference between encephalitis and meningitis?
Yeah, encephalitis and meningitis can be caused by a variety of organisms. It can be bacteria, viruses, or parasites. When we talk about inflammation of the brain and the membranes around the brain, it's really a continuum. So what we call meningitis is serious, but usually starts with inflammation of the membranes around the brain, the meninges. Most infections of the brain, of the spinal fluid, for example, start by causing inflammation of the meninges, and as it gets worse, it may progress to involve the brain tissue. So inflamed meninges or meningitis is usually presents with one or more of the classic triad of fever, changes in mental function like lethargy or difficulty waking up, and stiffness in the neck. And when we talk about neck stiffness and meningitis, it's difficulty bending the neck forward, not side to side. It's not so much that, but if the patient cannot touch the tinge of the chest, or when we examine a patient, we can't push their head forward so that they can touch their chin to their chest. Those are classic signs of meningitis, and severe headache, of course. A couple of the classic tests for meningitis are the Brudzinski and Koenig sign, where we'll do the bending of the head forward. That causes the hips and the knees to bend, and that's Brudzinski sign. It's hard to remember Brudzinski sign. The knees will bend. Koenig sign is more when you bend the hip and the knee to 90 degrees where the patient is lying down, and they won't let you extend or straighten up the knee. That's another sign of meningitis. When you have infection of the deep brain tissue, or in the case of severe meningitis, when it spreads into the brain tissue, then we call that encephalitis. And people with encephalitis will have more severe symptoms. They'll generally have fever and confusion, maybe even hallucinations in addition to headache. They may start to have seizures due to swelling of the brain tissue. And viruses like herpes simplex, for example, they may present with confusion and hallucination and fevers in a young person. That would be encephalitis primarily. And all that said, there's no definitive way to rule out meningitis or encephalitis other than doing a spinal tap. So I generally say that if meningitis pops into your head when you're examining patient, you just go ahead and trust your gut and do a lumbar puncture, do a spinal tap.
Mm-hmm. Okay, something that's been in the news quite a bit lately is measles, even here in West Central Florida.
Yeah.
Dr. Gompf, what are some of the complications of measles, and how often do they occur?
Yeah, measles is very important for doctors to be aware of now because, unfortunately, it's on the rise globally. There's been a drop in vaccination rates, and it doesn't take much for measles to start circulating again. It takes about measles is one of the most contagious viruses we know, other than smallpox. So, it only takes a person with measles being in a room, and that measles virus will hang in the air for up to 2 hours after the person has left the area. You need at least 95% of the population to be vaccinated and have antibodies against measles to keep it at bay. So even if you have 6% of the population unvaccinated, then you start seeing outbreaks. And in the U.S., it's usually imported because for now, we really don't have measles that circulates But when a traveler brings it in, who happens to be unvaccinated, then you start seeing cases such as the ones that we're seeing in St. Petersburg, Florida. About a third of patients will have complications from measles, and the commonest complication is ear infection. Maybe 1 in 10 cases. Some of those individuals will lose hearing permanently. And probably the most common and life-threatening complication is pneumonia. People don't realize that one of the complications is pneumonia. Maybe 1 in 20 may develop pneumonia, and that may be the cause of death. And fortunately, much less often, but 1 in 1,000 thereabouts, may get encephalitis again, and they may have deafness and seizures, and those situations may be permanent. One of the rarer complications of measles that may occur even years after an infection is subacute sclerosing panencephalitis. May occur in maybe about 10 in 100,000 cases. But it is a progressive, a degenerative neurologic disease. Patients will survive about 1 to 2 years before they pass away from progressive disease. And the only way to diagnose it is by finding measles virus in brain tissue biopsy. But once you have that, then you know what it is. It's very unfortunate.
Yeah, it sounds horrible. So that usually happens in young children that catch the measles, and then maybe a decade later. Mm-hmm.
Yeah, maybe even longer, even over 20 years later.
Yeah, that's incredible.
Yeah.
Let's talk about another virus. Why are antivirals not useful in treating infections caused by Epstein-Barr virus, like mononucleosis?
Yeah, we actually get that question now and then. Epstein-Barr virus causes the majority of infectious mononucleosis, or what we called in high school, when I was in high school, the kissing disease. Mm-hmm. Interestingly, we think that we're terribly sick when we have mono, but the symptoms of mono are really the after effect, the body's immune response to the infection. And by the time you have symptoms, replication of the Epstein-Barr virus has been controlled, and it's no longer in the blood. So antivirals, even though sometimes people will try them, you're not doing anything. Elvis has left the building pretty much.
Okay. Let's talk about a parasite, malaria disease. And malaria, of course, is caused by a blood-borne parasite called Plasmodium. How does sickle-cell trait protect against malaria or Plasmodium infections?
Yeah, that's really very interesting. Sickle-cell disease is a devastating genetic condition. It affects people of African descent. And somewhere along our evolutionary journey, a genetic mutation occurred in the hemoglobin gene. Hemoglobin A is the molecule that makes blood red, and it carries and releases oxygen from the lungs to all our organs when it gets to the small arteries. Well, this mutation produces a version of hemoglobin that we call hemoglobin S. When hemoglobin S releases its oxygen, it tends to clump up into long rods that change the round red blood cell into a thin sickle shape. It can puncture the red blood cell or break it, or more often those sickled red blood cells obstruct the small arteries, and it causes progressive damage to vital organs and really severe pain, joints and organs. And now people with sickle cell survive much longer, but early on, humans who inherited 2 copies of that sickle cell gene from their parents, they didn't live long enough to pass the gene to their children. You might expect that most people having this horrible gene would die early and the mutation would be lost to history. However, something sort of nifty happened, and people who had only one copy of that hemoglobin S gene didn't develop those severe symptoms. They did relatively well, and they were in areas where the Plasmodium falciparum malaria happens to be, and it's the most deadly form of malaria, and it remains an enormous public health burden. Mm-hmm. Well, several studies have shown that people with sickle cell trait are less likely to die from severe malaria than those without the mutation. And sickle cell trait is actually 90% protective against severe malaria, mostly severe malaria, and it's 60% protective against needing to be hospitalized. The CDC has gone back and they've found that it provides 60% protection from death in young infants and toddlers in areas where falciparum is highly transmitted. So there's a definite survival benefit for people who have one of those gene copies. And it's kind of a complicated situation. We're not entirely clear why that is true, but there are two major mechanisms that are proposed. The first is that the red cells, when people have sickle cell trait and they're infected by the malaria parasites, they sickle just enough to be removed by the immune system. So those infected cells get swept out. The second mechanism that's suggested is that the hemoglobin S disrupts the oxygen levels enough to slow down the growth of the parasite. So either way, the falciparum malaria is not going to be quite as severe in people with sickle cell trait. They may still get sick, but they're less likely to be as sick as people who have normal hemoglobin.
Interesting.
So in that sort of scenario, it makes sense that the trait would be passed down the generations in those areas. It's an interesting story.
Yeah, really fascinating. Dr. Gompf, what is Reiter syndrome and what GI pathogens are associated with it?
Yeah. Well, Reiter syndrome is a type of reactive arthritis, and it can occur sometimes a few weeks after certain types of infections. And usually it's gastrointestinal infections, but also some genitourinary infections. It most often occurs in young men who have the HLA-B27 gene, and it causes arthritis usually of the knee or just a few joints, and it can cause some other inflammatory findings. The most common gastrointestinal pathogens associated with it are Campylobacter, which you can get from chicken or eggs or raw milk, and Yersinia, which you can get from pork and poultry. And, of course, some Salmonella and Shigella can be a cause. It's probably important to mention that the most common urologic pathogen is chlamydia, which is actually a sexually transmitted disease. In people who have HIV and that HLA-B27 gene, they're more likely to develop Reiter's syndrome. They'll develop 75% of the time if they're exposed to these infections. So an important note is that people with Reiter should probably be screened for HIV.
Okay, urinary tract infections, really, really common thing in women. But let's talk about UTIs in men. Dr. Gompf, what are the causes of UTIs in men, and why do these infections sometimes require longer treatment times?
Yeah. Yeah, so yes, UTIs are very common, and it's actually very common to have bacteria colonizing the bladder as we grow older without any symptoms of a UTI. So male or female, a person has a UTI when they have burning on urination or increasing urination, feeling of difficulty or pain when starting to urinate, that sort of thing. UTIs in men are considered complicated to begin with because they're less likely to get infected in the first place than women. They have the advantage of a much longer urethra than women. So if enough bacteria were able to get to their bladders to set up disease, they probably have a heavier burden of infection. UTIs in men also tend to be related to obstruction to flow. So, when the prostate enlarges with age, or if they have a bladder catheter or perhaps kidney stones, that tends to be associated with UTIs, and especially recurrent UTIs. There are bacteria that will stick to stones and foreign materials like catheters, and they won't go away until that nidus is removed. The other thing is men have prostates, and prostates can become infected and provide a source of recurrent UTIs, but prostatitis may be difficult to detect, and it requires several weeks of treatment. So while we usually treat most women with maybe 3 days of antibiotics for straightforward bladder infection, we usually treat men for a week or sometimes longer. It depends on the severity of their infection or if we perhaps suspect prostatitis.
Okay, well, let me go ahead and close with this, and this is a question that I've heard asked 1,000 times over my career. Is bacterial vaginosis an infection? And if it's not, what is it?
Right. Yeah, I get that question too. Bacterial vaginosis is just a truly annoying condition. It affects many, many women. It's actually not an infection. It's an imbalance of the vaginal microbiome. It's not causing inflammation or damage. It's just an overgrowth of really annoying bacteria. At some point, what happens is something has disrupted the pH of the vaginal fluid, eliminated the protective lactic acid bacteria that are normally there. Now you've got a group of obnoxious, smelly bacteria that has just taken over the space, and it's raised the pH and it's made it unfriendly to the lactobacilli. And this may happen with sex. Can be actually, these bacteria may be sexually transmitted, or it can be related to hormonal changes, or perhaps having been treated with antibiotics, the flora has changed. Part of the reason that lactobacilli are an important part of the vaginal flora and protect against bacterial vaginosis is that they produce a natural peroxide. And that's how they lower the pH of the vagina, and that's how it keeps other bacteria from taking hold. One of the, probably other than being an annoying condition, one of the important conditions is bacterial vaginosis in pregnancy. It can actually pose a risk for preterm delivery and infections after birth. So obstetricians will look for it and generally treat it. That's the one situation where it's really important to manage it. Some of the symptoms of bacterial vaginosis it can be very embarrassing. Thin, watery fluid secretion. It can be stinky, and that an odor after sex may be an indication of it. It's easily diagnosed by a primary care doctor or a gynecologist. They just examine the fluid for bacteria and pH. It's easily treated with antibiotics like Clindamycin, and that can be taken by mouth or or intravaginally. But one of the home remedies that may be effective that I've recommended to some of my patients, it also helps you avoid antibiotics, which nowadays is increasingly important, right. Is a peroxide douche, up to 2 tablespoons of over-the-counter 3% peroxide daily for a few days. And there have been a few small studies that looked at this and found positive results and no harm, including some that found restoration of peroxide-producing lactobacilli. So it's something that I wouldn't do if I were pregnant or had some structural abnormality. And certainly you don't want to do something like that on a regular or routine basis, because then you're killing your own good flora too.
Mm-hmm.
But if you have bacterial vaginosis and you want to try it, it's certainly reasonable. There's some literature to support it.
Well, thank you for this very interesting Q&A on infectious diseases. Thank you, Dr. Sandra Gompf, for sharing your time and your expertise, ma'am. I appreciate it very much.
Sure. You're very welcome.